welcome. Just to introduce myself for the participant, I'm Professor Mohamed Nasreldin. I'm Professor of Psychiatry, Cairo University. I'm the head of Adolescent Psychiatry Unit in our hospital, our psychiatry hospital. Cairo University is a large university in Egypt. It is more than 100 years ago. It is ranked about 145. Its rank all over the world. Our role in our department in psychiatry is to diagnose, to recruit patients and diagnose and to receive the appropriate multidisciplinary team approach. Psychologists, nurse, social workers, psychiatrists, and the family are engaged. Families are engaged with us in the treatment of the adolescent patients. We have two sections: private section or economy section, and free section. Okay, the free section is totally free from A to Z. And the private section is very low cost for those who can afford the service. It is followed by the university staff, Cairo University staff of psychiatry. Total capacity of our hospital is 125 beds. We are treating males and females, treating addiction and mental illness, treating children. We have children and daycare for those with autistic spectrum disorder children. We have a yearly conference, international conference. We have weekly clinical conference showing the one of the difficult cases, sharing with the staff. We have daily rounds, clinical rounds. We have journal club to demonstrate and present the updates of the articles presented in the periodicals journal. We have also lectures, daily 10 clinics, receiving more than from 300 to 400 patients on daily basis, attending our clinics, doing psychotherapy, doing group therapy, different modalities of psychotherapy, CBT, DBT, and eclectic therapy, and supportive and family therapy. We have a peer supervision for those who are practicing, juniors who are practicing psychotherapy, and teaching them how to monitor, how to assess, how to manage dilemmas, psychotherapeutic dilemmas which they meet. Today, I selected the topic of facts about depression to be a relatively general topic, covering the area of stress and anxiety and depression. I focused on different facts about depression, and it will be presented next few minutes.
That's so much to know, Professor Mohamed. You are seriously are from a very big association, I would say, and that's why I could see your popularity on social media, on Facebook also. There were so many people asking about you and your event, and when you are coming up, wish they could attend the event. I could see that. I mean,
Yeah.
I was actually tracking that also. Our team could see that.
Yeah.
And no doubt you were so popular there, as I can sense something very different to learn about that is coming up in next few minutes.
Okay.
Yeah. So, with your permission, let us get to know about our next speaker also. Let us share a few words with Mr. Miele also.
Hi, thank you for having me. My name is Miele. I'm currently in New York in the US and studying at Brown University, which I think is ranked 129 in the world. I just looked that one up, so that's pretty cool. But definitely excited to come and speak. What I am is I'm a founder and CEO of a company called Turbo Relief, where we specialize in making products, physical products that are drug-free to combat these symptoms and help in a physical way. I'll get into that later, but just stuff we work on are those sort of physical products for children, elderly adults, the most needing groups and demographics, as well as making DBT curriculums around these sort of products to really make an impactful physical change. And that's sort of my role as creator and developer. So I'll pass it on to the next speaker.
Thank you so much, Mr. Rayan. I am really looking forward to so many insights and get to know so many other facts about Turbobo also. But I can say that last time when I saw your introduction video and many of our other attendees in the last event, when they saw that, they all were saying that we don't know about the facts or the science it could be having behind it, but we are feeling already better watching Turbobo. That was such a cute like a little toy, but obviously we are looking forward to what else it is hiding behind it.
Excellent.
Yeah. So let us know, thank you so much for your introduction, and let us know about Miss Helen also.
Hi there, everyone. Can you hear me well enough?
Perfectly.
Wonderful. Thank you so much to my previous speakers. Also, I look forward to learning a lot about your areas of expertise. I'm a clinical psychologist working in Cyprus. I have done this profession 25 years transculturally, also working in 13 different countries, presenting innovative, I could say, but actually quite well established by now, creative solutions for anxiety, depression, sometimes addiction recovery as well, using rhythm and a process called entrainment. Working in private practice, but also work cross-culturally and do various community development projects using rhythm percussion for youth. And I'm very excited to share today what has become a plethora of deep science and increasing research on the way that drumming and rhythm specifically is lowering cortisol and adrenaline levels, and really also adjusting the neurotransmitters in the brain when it comes to depression, anxiety, and such symptoms. We can see some very interesting results after 3 months of regular playing with an instrument, specifically rhythm-based, because it has a specific way of changing the brainwave consistency. So I look forward to seeing you all again. I'm going to be driving, but listening to you and then landing somewhere safe and solid to present. Thank you so much to everyone. And thanks again to all of you at OLCIAS.
Thank you so much, Miss Helen. I would call it Miss Helen Aha, as she suggested last time. So definitely, she always come up with some very different, some very not so common topics, as she has been our speaker since our last 2 events also. And this time as well, I'm definitely looking forward to how to control anxiety with drumming. Looking forward to it. All right. So here, let me share a few guidelines before we start our very first presentation, everyone. So about the questions or answers we might be asking from our speakers, right? So in case you are having any question while the talk presentation is going on, please raise your hand or write down your question in the chat box or in the comment section. For comment section is for the LinkedIn Live attendees. So you can write down your question in the chat box for the meeting room attendees and in the comment section for LinkedIn Live attendees. This way we'll be having the question in our note, and if the speaker is comfortable to answer the question right away, he or she will take the question. Okay, so we won't be making it chaotic in any way. So Also, you can ask your questions later also, as after we'll be done with the 3 talk presentations, we'll be having a questionnaire session, especially for the questions or the queries or the things you would like to discuss. And with the likely-minded people here in the meeting room today, let us start with our very first talk presentation, everyone. Please welcome Professor Mohamed Nasreldin.
Hi.
The screen is all yours.
Yes. Good afternoon, everybody. Let's talk today about my presentation, which is Facts About Depression Overview. First, I would like to express my deepest appreciation to Mrs. Ghazal Johar, Conference Manager, for her efforts and facilitation of any obstacles we have faced during preparation of this presentation. Extending my appreciation to Dr. Margarita for providing me with this opportunity to participate in this online conference. No conflict of interest. I'm the one who collected and prepared all the presentation scientific content. Let's see, what is it? 24-year-old female, first time at your clinic, no available past medical records, presenting symptoms, insomnia, crying spells, low energy, irritability, and social isolation. Hopes you can help her to feel better. She looks been depressed for years, but worsened over past couple of months, denies suicidal thoughts. Let's see together, what is a DSM diagnosis, including prominent depressive symptoms? Adjustment disorder with depressed mood, persistent depressive disorder, formerly dysthymic disorder, major depressive disorder, and bipolar depression, premenstrual dysphoric disorder, and schizoaffective depressive type. And there are other DSM-4 diagnoses that commonly have comorbid depressive symptoms, such as post-traumatic stress disorder, substance use disorder, and other addictive addictions, such as game addiction, personality disorders, especially borderline personality disorder, and the comorbidity with other anxiety disorders, panic disorder, social phobia, generalized anxiety disorder, obsessive compulsive disorder, eating disorder, and gender dysphoria. And there are a lot of medications that cause depressive symptoms, such as narcotics, antihypertensive medications, proton pump inhibitors, statins, anticholinergic drugs, hormone replacement therapy, steroids, beta blockers, benzodiazepines, Parkinson's medications, anticonvulsant and stimulant. And all of these medications may induce depression and cause depressive symptoms, and it may induce depression due to medications. And there are a lot of life situations may involve depressive symptoms, grief after loss of significant figure, partner relational problem, and we face this a lot in our clinics, end of a relationship or divorce, infertility, miscarriage, abuse, violence, intimate partner violence, and domestic violence are one of the most common causes of stress and definitely depressive symptoms or depression. Postpartum depression, hypothyroidism, Parkinson's disease, dementia, delirium, stroke, and cardiac issues. And cardiologists are now placing depression as one of the risk factors of recurrence of myocardial infarction and should be treated appropriately if the patient has any cardiac problems. chronic pain is definitely a stressful situation, and the raising diagnosis fibromyalgia. Multiple sclerosis is definitely one of the most common causes of and medical issues causing depression and diabetes. When we see depressive symptoms can be rooted in many different causes. And so assessment takes time and energy. We don't take depressive symptoms lightly. We have to dig down to root any other secondary medical conditions or drugs that may cause depression. So appropriate treatment follows accurate assessment, not to miss any appropriate data helping our patient in diagnosis. What does the patient feel? You feel anxious, empty, worried, guilty. So the DSM-5 criteria for diagnosing major depressive disorder, we have to find 5 or more of the following symptoms, at least for a duration of 2 weeks, and representing a change from previous functionality. Depressed mood or anhedonia, loss of interest, significant change in weight or appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy. A lot of females coming to our clinics, they are and referred from other specialty clinics, they are easily fatigued after minimal effort. When assessing them, we find other criteria for major depressive disorder, and diminished ability to think and concentrate, and might be the first symptoms also, yet we have to find whether anhedonia or depression or depressed mood as core symptoms of depression to diagnose major depressive disorder, and recurrent and the suicidal chain, which started by thoughts of death, suicidal ideations, suicidal plan, suicidal attempt, and finally commitment. And the depressive symptoms have definitely effect on functionality of the patient, lowering his performance, lowering his interpersonal relations, lowering his cognitive abilities. And the specifiers of major depressive disorders, according to DSM-5, whether it is with anxious distress and mixed features. When we find mixed features in patient with major depressive disorder, we have to be carefully looking for bipolar depression, or mixed features might affect the prognosis or might affect the management plan. With melancholic depression, also, it is very important specifier with major depressive disorder criteria, as it has effect on management plan. We might add with depression, antidepressant, minimal doses of antipsychotics if the patient is not properly responding, or if it is severe, it might use interventional equipment such as electroconvulsive therapy. And the atypical presentation, which might start with hypersomnia or hyperphagia and reactivity of mood, and sometimes it is called smiley depression. Whether it is associated with mood congruent psychotic features or mood incongruent psychotic features, it's also very important specifier, as it reflects the severity of major depressive disorder presenting by the patient. Peripartum onset or catatonic features, it is not very common, but sometimes we face patients with catatonic features, whether it's catatonic stupor, and it's more common than catatonic excitement, and with seasonal affective symptoms or seasonal pattern. It's also important to look for seasonality of the presentation, as it affects our management. We can prevent the further episodes if we know that more or less the season of exacerbation of symptoms, as it affects its prognosis, and raising the medications before the expected onset of the illness, and the patient can be prevented from developing another episode of major depression. And the severity of the episode ranging from mild to moderate to severe, and the patient we are assessing reaches full remission or partial remission. Partial remission is not a good sign of management, as it maintains residual symptoms. The residual symptoms of depression is a predictor of future relapses. And so we have to treat the patient properly and no residual symptoms. The course may be episodic, recurrent, or subclinical depression. Sadness plus 3 other symptoms may be presenting for 10 days in the patient. When you look at this slide, it's DALS, it's disability and affecting daily, disability affecting daily living and handicap. It's percent of years lost by unipolar depression. It's one of the first of the neuropsychiatric disorders affecting the lives of our patients. Almost 10 years or 10 years are lost from the expected life expectancy by mortality, increasing mortality by suicide, or morbidity by comorbidity of other psychiatric disorders or physical disorders. The incidence of depression, when we look at over 2,000 patients, 10 will reach depressive symptoms or depression. 10 will be major depressive disorder patient, 100 major depression, 100 minor depression, and 200 are subclinical. Almost 50% of patients, it might be not acknowledged and missed. So we'll look together for some numbers. 10% of those diagnosed in primary care are referred to psychiatrists. Only 10%, they consult primary care, and the 10% only will be referred, whether it is not proper referral or it is the severity, it's not severe. 1 in thousands are admitted to hospitals. Lifetime incidence rates approach 33%. 5% of consultants have major depression. 5% have milder depression, according to the severity. A further 10% have some depressive features. Continuing the numbers, at least 1 patient per surgery, looking at other general specialties surgery, have depressive symptoms at some time. Commoner in young people, including children, than in the adult, than in the past. Now we see depression in children more common and more prevalent than previously in the past. The male to female ratio, female are more common, twice more than male, men, due to hormonal changes and different roles they play in the life. Common in the physically ill, it's chronic stressors. 50% recurrence rate, which is a chronic recurring disorder. 12% become chronically depressed due to residual symptoms or resistant to respond to treatment. Major depressive disorder is a leading cause of disease burden, as we mentioned before. Remission is the important goal. When we set the management plan, we have to reach remission, full remission, no residual symptoms, as residual symptoms play a role of a predictor of future relapses and recurrence. Augmentation is one of the important treatment strategies to reach achieve remission and reach remission. When we treat depressed patient, we face different categories. One will respond, one will be resistant to respond. Those patients who are resistant to respond, will try to manage and overcome this resistance by whether maximizing our doses of medications or adding another medication combination of antidepressant medication, or augmenting it by different class of another psychotropic medications, or shifting the medications we started by it. Effective management of major depressive disorder continues to be challenging task for psychiatrists. When we face a depressed patient, definitely it's challenging, as 60% of patients are not achieving adequate response following treatment with antidepressant medications. There is a rise in cases of major depression. The WHO said that ahead from the World Health Day, focusing on depression, The World Health Organization said that depression is the leading cause of ill health and disability worldwide. WHO latest estimate says over 300 million of people live with depression, an increase of more than 18% between 2005 and 2015. It's a high rate. One 21 million people all over the world are complaining from depression. So it is very challenging. Depression is not only a disease of mind, it's a brain, body, and mind also. We find somatic consequences of major depressive disorder and morphological changes in the brain, and definitely depressive symptoms and functional impairment following manifestation of major depression. So it is not only a disease of mind, it's also brain and body association. Here is a heterogeneous clinical features of major depressive disorder. Major depressive disorder can present with many of symptoms. As we mentioned for the DSM-5 criteria, depressed mood, loss of interest, loss of appetite or appetite changes, sleeping issues, loss of energy, feeling worthlessness, difficulty concentrating, thought of death and suicide, hopelessness and helplessness are also symptoms of major depression and might be one of the predictors of suicidal plan or suicidal intentions. When you find a patient with hopelessness and helplessness and previous suicidal attempt or plan, definitely it's very high suicidal risk. It's have its effect and reflection on work, days of absenteeism. It's increasing in patient with, in patients with major depression, higher body mass index due to decreased energy and stagnation at home, and might overeating or decrease burning of foods, increasing its body weight, higher risk of comorbidities. Depression is very highly comorbid with other medical conditions, and it might be associated with other psychiatric and mental conditions. So significant impairment in social, occupation, and other important areas of functional is very important. On average, just 3% of government health budget is invested in health, in mental health, varying from less than 1% in low-income countries to 5% in high-income countries. They added that every US dollar, $1 invested in scaling up treatment of depression and anxiety leads to a return of $400 in a better health and ability to work. Definitely, the reduction of use of other medical specialties, unnecessary investigations and medications, what be prescribed for those with somatic complaints, and absenteeism from work and days lost from work. All these are lost costs, indirect costs, and direct and indirect costs in calculation of the burden, financial and economic burden of depression. So investing in treating mental patients and especially depression is very important and crucial. What are the secret symptoms of depression? Excessive negative thoughts. Let's see together. Depression is a liar. Definitely, you are lazy, you are worthless, you are never going to amount to deserve and not important for anyone. You have to escape, you have to leave them, you have to, all people are hating you. All people you are a garbage, the core of which is negative view of self and negative view of others and negative view of future. In addition to some secrets, depression is bully. It's a sneaky, manipulative bully. Not only that, it's sneaky, manipulative bully that knows all your weaknesses and tender spots, and it presses on it. to raise your pain, to raise your low self-esteem, to raise your sense of rejection, and to raise your embarrassment and emotional wounds you have ever sustained in your life. Definitely, it's bullying and liar. Excessive self-isolation. So I am bad. Others are hating me. I'm rejected. So I have to isolate myself, not to face, not to engage. So I have to induce pain and inflict self-harm. If you think you might be depressed, you have to tell somebody. It's not a secret. It's not stigma. You have to tell. Suicidal thoughts also aren't always part of depression, but if it is present, I have to act aggressively to manage the patient up to hospitalization if it is genuine suicidal and high suicide risk. Depression and sadness are not always the same thing. If I am sad due to loss of some of my object, of some important issues, it's not equivalent as depression. It's normal reaction. But if I am depressed, I have the full symptoms required by DSM criteria for diagnosing the disorder. And it is a disorder affecting mind, brain, and body. You can be depressed without knowing it. If I'm still functioning, but my functionality is decreased below my expectations and still reactive, and reactivity still present during my interaction with others in social context, it might be hidden, or I don't know that I'm depressed. If I'm complaining from somatic complaints and consulting other specialties rather than the psychiatrist or psychologist, I'll not know that I'm depressed until they diagnose me. There is no other cause of your complaints, no significant physical cause of your complaints. So you have to consult the psychiatrist. Depression can be visible when it is severe. People contacting with me will definitely notice my change and my affective expression of depressed mood. So they ask me what is going on. Depression responds to routine and structure. When I'm living in unstructured environment and setting some structure, it will definitely affect my depressed moods. So might be easier to live and easier to contact, yet it's not the proper and first line treatment of depression, but setting routine and structure helping in treatment of depression. Depression is not the end of the world. When people those who are complaining from depression or major depressive disorder, depression is extremely painful up to the limit. They narrow their vision to the world, to themselves and to the others and the future. So they consider it the end of the world and wishing to die, and they are overwhelmed with the pain of major depressive disorder and their weakness. The treatment of depression, where we are today. Second and third treatment associated with worse outcome. When we start with antidepressant treatment for treatment of major depressive disorder patients, if the patient responded properly, it's good. But if he didn't show a good response or partial responders, trial of second and third lines of treatment is associated with definitely worse outcome, and we start to think about resistance of response. Mostly 30% of patients treated with major depressive disorder are categorized are resistant to respond, and there is a management of treatment of depression, resistant depression. Augmentation, as we mentioned before, is better strategy for managing those who are complaining for resistant to respond than switching, as we save time for the patient by adding extra psychotropic medication to enhance improvement, whether it is second generation antipsychotics, whether it is another category anticonvulsant, such as lamotrigine or other medication. Without remission, recurrence is common. So the target and management plan, first objective of the management plan is reaching remission, as recurrence is very common in patients with residual symptoms. Partial remission is delayed with is associated with a delay in access to effective treatment. These are some terminologies we have to be aware of it while managing and assessing patient with antidepressant and with major depressive disorder. Non-response, no response requiring change in treatment. Hamilton is more than 50%. Response, good enough response to change. Hamilton decreased significantly below 7. Remission, 2 consecutive months of asymptomatic stage. Recovery, reaching remission and followed by functional recovery. Treatment-resistant depression, partial response to treatment and maintaining those symptoms and not consequently improving. Treatment refractory, no response to treatment at all. 60 to 70% tolerant patients respond to first-line monotherapy. Up to 50% treated with single antidepressant don't reach full remission. Third of patients become treatment resistant, as I mentioned. Here is a strategy of treatment of resistant depression. We are facing challenges. One of the first challenges is that operational definition of treatment-resistant depression. When at least 2 appropriate antidepressant trials of proved efficacy of good dose from 2 different pharmacological classes fail to produce significant improvement at optimal dose for sufficient period of time, it's treatment resistant. And treatment resistant patient is very challenging for psychiatrists, as some psychiatrists refuse the term resistant as it causes frustration for them and consider it as treatment non-responders. It's better term for them. What are the predictors of poor responders? Access to personality disorders and the comorbidity of personality disorders among major depressive disorder, such as cluster B personality disorders, borderline or antisocial personality disorders might affect the response rate. Comorbid anxiety or other different classes of anxiety, social anxiety, generalized anxiety, panic disorder, delays in initiating treatment or chronicity. The duration of untreated depression, definitely it has an effect of on response to treatment. When the duration of untreated depressed patient is prolonged, definitely response rate will be lowered. The comorbid substance use has its negative effect on response rate. The presence of positive family history, extremes in age of onset, whether it is young or old age geriatric, and definitely general medical conditions as a comorbidity or other use of other medications has its effect on response to treatment. Depressive subtypes, especially bipolar depression. There is an important term which is pseudo-resistant. Pseudo-resistant, when the patient come to the clinic and ask him, are you using the medications? Yes, I'm using it. But sorry, doctor, I didn't show any improvement. When checking the compliance of the medications with him or his informant, we find that he's not totally compliant. He misses doses. And inadequate dosing by especially with the primary care physicians for fear of side effects, definitely it has its effect on response to treatment by the patient and has its negative effect on the remission. Early treatment discontinuation after improvement and the patient showed improvement and he discontinued treatment very early. Misdiagnosis, and I diagnose the patient as major depressive disorder and might be with mixed features and might be diagnosed as bipolar spectrum disorder patient. Why missed? 50% are missed, 10% subsequently recognized. 1 of 40 who remain unrecognized, half remit spontaneously, half remain depressed 6 months later. There are patient factors, present somatic symptoms. They consult other specialties. Physical problems, they have physical problems such as renal or cardiac problems or liver problems. Stigma, for fear of consulting psychiatrists and for fear of being stigmatized among their families and their friends, being weak, being depressed, especially in uncivilized or undeveloped countries. Beliefs about general practitioner role and time to listen. The general practitioner role and family medicine consultation, he faced a lot of patients, a huge number of patients, and the time to listen is very short, so they are missed and they are hiding their complaints. Long-standing depression, definitely it's one of the important factors. Less overt and typical. It's not typical in presentation. Less insight, especially when it is associated with psychotic features such as delusion of reference or delusion of persecution or most common nihilistic delusion. And there are doctor factors are responsible for missing the diagnosis of depression. More accurate doctors make more eye contact. We have to listen to our patient appropriately, not in a hurry, no sign in a hurry, giving them time with more eye-to-eye contact to be a good listener and understanding the social and psychological content, to understand the psychopathology and the pathology of the presentation, and asking more questions to elaborate the presentation to reach the appropriate assessment and appropriate diagnosis and not to miss patients. Less accurate doctors ask many closed questions, such as, what about is it okay or not? You have to ask open questions to verify the symptoms and to reach the appropriate diagnosis, not just to fit or close and terminate the interview. The unmet needs in the major depressive disorder, lack of biomarkers, not as other medical conditions. We don't have investigations such as cholesterol, such as CBC, ESR. We don't have specific biomarkers for major depressive disorder. It's unmet need. Lack of understanding of risk factors. Still, we know the risk factors, but not appropriately understood. Outcome predictors for major depressive disorder. Lack of effective major depressive treatment. Although there are a huge number of antidepressants, yet the very effective treatment of depression or major depressive disorder is not yet present. We have resistant cases, 30% of them resistant cases, and more than 50 to 60% of patients don't respond to first-line treatment of depression, antidepressant medications. No remission, despite the availability, as we mentioned, large number of antidepressants of different classes of antidepressant, significant portion of patients don't reach or don't achieve remission, and treatment resistance is common. What are the medical conditions very common presenting with major depression? Cancer, definitely. 25% of cancer patients experience depression. Strokes, it's very common after neurological insults, especially cerebrovascular strokes. 27% of post-stroke patients experience depression. Heart attacks, as I mentioned before, it's considered as one of the important risk factors to be managed after heart attacks. HIV is one of the important infectious diseases that causes major depressive disorder or associated with major depressive disorder. Parkinson's disease, And the triad of Parkinson's, depression, and dementia is very common, as 50% of Parkinson's disease patients may experience depression. Eating disorder, 50 to 70% of those patients with eating disorders are complaining from major depressive disorder or depressive symptoms. Substance use, 27%, as it's very high ratio of individuals with substance use disorder, alcohol and other substances experience depression. Diabetes, 27% also of persons from 8.5 up to 27% may experience depression, whether it is secondary to diabetes or comorbidity with diabetes. The somatic complaints or medical conditions and their association with clinical depression, insulin resistance, COPD, infectious disease, cancer, cardiovascular, as I mentioned, irritable bowel syndrome, chronic pain, autoimmune disease are very commonly associated with depression. 31% only of patients with major depression without somatic complaints, while 69% reported physical symptoms. It's very high percentage. So we have to exclude physical symptoms in depression and ask about it. What are the aspects facilitating somatic symptoms in depression? Being a female, it is more acceptable to consult other specialties in a female rather than psychiatrist for fear of stigma and the acceptance of the family to consult the psychiatrist. Younger age of onset, they are less expressive, so they express somatic complaints of stress and anxiety and depression. The presence of stress and trauma, the manifestation of stress and trauma may start by somatic complaints such as headache, abdominal pains, fatigue, joint arthralgia, and anxiety symptoms comorbid with depression. Definitely, the weight of somatic complaints will overcome or hide the depressive symptoms. Less satisfaction from care. So I have to consult the physicians and other specialties rather than the psychiatrist. Culture and society. Some cultures are not accepting the psychiatrist or stigmatizing their patient if they're consulting the psychiatrist. The doctor-patient relationship is one of the important factors for adherence, diagnosis, and maintaining the good alliance with the patient is one of the important factors for facilitating and understanding their complaints, even in physicians and other specialties. Ages, medical conditions, and lower income. Lower income and medical conditions, sometimes they are alexithymic. They cannot express or identify their emotions. We have to consider comorbidity. 43% of people who suffer from anxiety are also suffering from depression. 2/3 of patients with major depression also suffer from some level of anxiety. Here is a step rising of the goals of management of depression. The target is increasing. Before 1990, the target of management plan was symptom reduction. It increased reaching response to antidepressant. At 2000s, remission was the target to reach symptom-free. Then improvement of functionality and reaching functional remission with no symptoms and full recovery. Improving the quality of life after 2010. So the symptoms of side effects of medications and reduction of side effects and focusing on different domains of depression, not only the mental domain, cognitive domain, social domains, and other sexual domains. So improvement of side effect profile of depression is one of the important steps in management plan. Selection of medications of antidepressant is based on specific depressive symptoms, comorbid conditions, safety, side effect, and tolerability of the patient, concurrent medications and drug-drug interactions, ease of use, frequency of administration, patient preference or expectations, cost and insurance coverage, response to antidepressant during prior episodes. If he responded to one antidepressant previously, I have to select it when prescribing it again. Family, first-degree relative history of response to antidepressant, it might be considered one of the important factors in selecting antidepressant. There are depressive symptoms presenting by the patient: sense of guilt, irritability, fear, and anxiety, and impulsivity, and even suicide. There are serotonergic depression might prescribe antidepressant with serotonergic efficacy. Epinephrine depression, lack of motivation, impaired healthy cognition, lower intellectual skills, inactive, lower arousal, poor appetite might prescribe antidepressant of efficacy of epinephrine efficacy. Dopaminergic depression, loss of pleasure, enjoyment, anhedonia, and energy, loss of interest, lack of motivation is dopamine depression, and might use selectivity in serotonergic reagents or combined SNRIs or dopaminergic drugs, Wellbutrin or bupropion. Finally, close my presentation with Mother Teresa quotes. If you judge people, you have no time to love them. Peace begins with a smile. We fear the future because we are wasting today. Don't waste today. Not all of us can do great things, but we can do small things with great love. Yesterday is gone. Tomorrow has not yet come. We have only today. Let us begin. Every time you smile at someone, it is an action of love, a gift to the person, a beautiful thing. Kind words can be short and easy to speak, but their echoes are truly endless. Don't think that love, in order to be genuine, has to be extraordinary. What we need is to love without getting tired. The most terrible poverty is loneliness, and the feeling begins of being unloved. It is not how much we give, but how much we love, put into giving. A life not lived for others is not a life. I prefer you to make mistakes in kindness than work miracles in unkindness. If you find happiness, people may be jealous. Be happy anyway. I alone cannot change the world, but I can cast a stone across the waters to create many ripples. Thank you for your attention.
That was great, the whole presentation, but the last slide, the quotes from Mother Teresa was, thank you so much. It was worth a thank to Professor Mohamed. And thank you so much for highlighting the widespread impact of depression, addressing its effects on work, our education, our relationships, our health, and emphasis on global statistics, and underscoring the urgent need for increased mental health care and its investment and reduced stigma. There was a lot we learned from Professor Mohamed. Thank you so much.
My pleasure. It's my pleasure sharing this presentation with you.
Yeah, and there was a line called "Depression is a bully." Indeed, Professor, the depression is a bully, as we could see. According to the latest statistics in 2023, there were about 7 lakh of suicidal cases.
Yeah.
So yeah, we must not let a bully win, anyways. So yeah, let me ask if we are having any questions to be asked from Professor. We are having so many appreciations from LinkedIn Live as well. Okay, there are questions in the chat box. The question is from Miss Helen as well. Okay, great. She is on screen. That is the best way.
Thank you, Professor. Wow, very amazing, comprehensive introduction, and you went very deep. You mentioned initially something about before you started explaining the non-responsive patient, you said at the beginning when you were giving the stats of the 1% budget of government onto mental health in low economic countries, and then you mentioned 5% in higher, and then you mentioned 3% is the average mental health budget. I think just around that point, you mentioned something about 60% of patients are responding to the treatment, and then later you explained it was half or 50%. I just wondered if you could explain that a little bit more. Is it that 60% of people reporting depression are responsive to the medication, or is it?
Yes.
I wanted a bit more clarity.
Definitely, the response rate is for the first line treatment. We have algorithmic management of depression. These algorithmic management of depression started by first line, second line, third line, and so on. The response rate to first line of major depressed patient is ranging from 50 to 60%, not only. So we have to shift to the second line to improve the response rate. The response rate to the second line of major depression is improving by adding or adding extra antidepressant, or augmenting the effect of the first line antidepressant by adding second generation or anti-epileptics. So there is also a percentage of non-responders after the second line of treatment. Okay. So switching to the third line of treatment, still adding extra or augmenting by adding, and the final network of non-responders or poor responders reaching almost 30% of patients. They are not properly responding to antidepressants.
Okay, and can I take it one step further? Is there any sort of reliable comprehensive research explaining that statistic, depending on whether the patient is reporting after grief or maybe after an addiction or comorbidity with other diagnoses? Do we have any information about that resistance?
Yes, there is a predictor. As I mentioned, yes, we have articles explaining that the presence of comorbidity, being a female, being at extremes of age, being delayed in receiving treatment from the onset of action, it's predictors of poor response to antidepressants, and comorbidity of comorbidity of other anxiety disorders, substance, borderline, or other personality disorders are considered predictors and of poor response or treatment resistant.
Got it. Thank you so much.
I'm much welcome. Thank you.
Thank you for the question, Ms. Helen, and thank you for taking up the question, Professor Mohamed. So we are having one more question from Ms. Neha, I guess. So Ms. Neha, is it okay with you to come up on the screen and ask the question, or unmute yourself at least? Otherwise, that's okay. We are having the question here.
Yeah. Hello.
Hello. Hello, Ms. Neha.
Hello, Professor. Yes.
Hello. It's my pleasure.
Yeah, it's my pleasure. Hope all is well. So given your expertise in adolescent psychiatry, how do depressive symptoms manifest in adults compared to adolescents? And are there unique challenges in diagnosing and treating depression in different age groups?
Yes. Thank you for your good questions. It's excellent questions. Let's start by the second part of the questions. There are a lot of challenges in different age groups, especially adolescent. Adolescent brain is quite different from adult brain. They are more impulsive and more emotional than the adult brain. And being more impulsive and more emotional and less developed dorsolateral prefrontal cortex, so their depression is manifesting might differently from adult presentation by behavioral changes, substance use, reckless behavior, neglecting academic performance, disturbed relationships, So the presentation might be different in adolescent due to poor development or less developed dorsolateral prefrontal cortex, and they are more impulsive and more emotional in their development. And on the other side, the old age group are presenting with more somatic complaints than emotional complaints. They are manifesting by different pains all over the body, and anxiety symptoms and sleep disturbances might be the core presentation of old age depression. And the adult depression, the core symptoms is anhedonia and lack of interest and depressed mood. Also in elderly, the depression and depressed mood is manifesting by suicidal ideations in old age and rejection of medications or interventions that might control their secondary medical conditions they are complaining from and receiving treatment for. This is the second part of presentation. Also, there is different presentation of depression in female gender, different presentation. They are more somatizers and more emotional and crying and affecting their sleep more than male gender. Male gender might present their depression with suicidal, with depressed mood, and work performance deterioration. The other part of the questions, adolescent, I responded already. Is it right? If the onset of depression started early onset at adolescent, definitely it will be more chronic and relapsing more in adult, and the symptoms response in adolescent might be poorer than in adult due to their compliance and comorbidity of substance use and awareness of their needs of to be adherent to medication. So the depressive symptoms might continue during the adulthood when it starts during adolescence. Thank you.
I hope.
Thank you, Professor.
Thank you.
Thank you, Neha, for the question. Miss Helen would like to ask one more question.
Professor, there's a lot of talk nowadays about dopamine addiction. And we all know technology is a very big factor in a lot of mental health issues, especially for young people, you know, spending a lot of time increasing certain, you know, neurological kind of chemicals in the brain by being very active online, dopamine increasing also with many different types of use with technology. Can you comment a little bit about how that's affecting the picture, the profile of depression in young people? And how it's sort of changing the profile also when it comes to anxiety, when I know there's, you know, cases where we see the depression and the anxiety.
Okay. Thank you for your wonderful questions. Definitely, it's very challenging when we face depression and we face adolescent patients with dopamine dependency by the smart phones or games addictions or other technologies use. It's very dependent on the severity and support system of the family and the cooperation of the adolescent. It's very challenging to manage such cases, especially when it is comorbid with scholastic or academic problems, family diversities, or family stressful situations, or being neglected, being in a divorced parents, or family corruptions, or family impairment of dynamics in the family. The support system definitely will affect the prognosis of the patient and the management plan. Sometimes some of these patients who are totally dependent on smartphones and the technology, and they are not cooperative and not motivated to engage in the system or management plan, they are hospitalized to cut the cycle of addiction and dependency, and they are admitted involuntary, depending on the involuntary hospitalization, as they cause serious and significant consequences on their life, and by the law they are harmful to themselves. Okay, not only the dependency on technology, but also on self-inflicting self-harm and self-injurious behavior, and a lot of comorbid substance use, depending in comorbid with games to enhance more dopamine and more pleasure-seeking behavior. Do you have any more elaboration or questions?
There are a few questions, Professor Mohamed, but as we are walking ahead of our schedule, the time, it's already like 10 minutes, 11 minutes ahead of Mr. Rayan's talk presentation.
Okay.
So yeah, I would like to ask for, I would like to request exactly to those who are asking the questions, and to you too, that can we please ask the questions in the questionnaire session? Will that be fine? We will ask the questions, or we will be discussing the questions asked from the LinkedIn Live as well, and those who are asking the questions here. After we'll be done with 3 talk presentations planned for the day. All right. With your permission, Professor Mohamed, we would like to request Mr. Rayan to come up and give his talk presentation, or introduce Turbobo, the cute Turbobo, with us.
All right, let me just
Yeah, thank you so much. And yes, we'll be discussing the questions later in the questionnaire session, everyone. Please don't forget. Stay connected. Thank you.
All right. Thank you so much, Ms. Ghazal, for setting this up and inviting me on. Thank you, Professor Mohamed. What an amazing talk about depression. I'd like to kind of switch gears a little bit and focus more on anxiety and stress, and sort of use this sort of creation of mine called Turbobo to kind of run through a very simplistic explanation behind anxiety, stress, different strategies to remediate its symptoms and actually get a better quality of care as a resource from using like talk therapy or other psychiatric methods to enhance your sort of well-being. So moving on. So my name is Ryan Miele. I'm the founder and CEO of Turbo Relief. Here's my email website, and let's get into it. So this is just Meet Turbobo. This is just to put a face to the name. What it effectively is it's an anxiety reducing stuffed animal. My sort of venture focuses on making physical products and or other therapies to really enhance the quality of care of physicians, as well as make it more accessible to those needing extra anxiety relief. So this is just to put a face to the name. It has, so on the outside, you'll notice it looks like just a regular stuffed animal, but there's a lot more under the table. So before we get into what it is, let's talk about some quick anxiety statistics from the US, because I'm originally from New York, and this is sort of my kind of tri-state region that I'm sort of exploring these different avenues. So to start with, approximately 47% of the US population, which is about 158 million people, live in a mental health workforce shortage area, especially in cities, especially those that are economically stressed. I know Professor Mohamed talked a lot about access and how there's a lack of, and there's no difference over here on the U.S. side. It's pretty scary how the demand, especially after the pandemic, for stress, anxiety relief, and therapy has just skyrocketed. But the level and amount of um, qualified physicians to help address these sort of needs is not meeting the demand. So there's actually a great shortage here. And now it's sort of looking for ways to combat that. Next, we have childhood anxiety disorders are very common, citing 1 in 8 children are diagnosed with an anxiety disorder. Now, this is from the American Psychiatric Association, but these are those that are diagnosed with anxiety. There is still such a stigma around even saying you have a mental health, what some people call it a weakness or something along that lines of needing support. There's still a very strong stigma around, no, I must be strong or not for me. But in reality, it's a very much bigger issue than what's being recorded. But the fact that 1 in 8 are coming forward with this anxiety disorder and being diagnosed just speaks to how grave a challenge it is right now in our society. Next, again, from the American Psychiatric Association, there's this idea that kids will outgrow these problems related to anxiety, but the evidence doesn't support that. Without treatment, childhood anxiety is likely to persist, negatively affecting a child's social and family functioning and overall quality of life. So it's very clear from an adult population of individuals over the age of 18, let's say, who have these sort of anxious and stressful disorders, but I think it really stems from the youth and from a childhood and from not getting diagnosed or not receiving treatment. And those things sort of fester and making it even worse and harder to kind of take out of someone's life to make their life better in those older ages, because people get so rooted in their ways that it seems the best way to sort of prepare for the future is to use almost like a preventative strategy as opposed to reactionary. Because right now we have a lot of reactionary tactics such as medical drugs or supplements or a lot of these things that are kind of being given to those when they're at their worst, but there's not so much of a focus on preventing it from even getting there as there is from reacting to it as is. So that's something that I'll speak a little more into as we progress. And the next, according to the American Association of Geriatric Psychiatry, anxiety is a common illness among older adults, affecting as many as 10 to 20% of the older population, though it is often undiagnosed. Phobia, when an individual is fearful of certain things, places, or events, is the most typical type of anxiety. So I just spoke a little bit about the adolescent end of the spectrum, but now let's look at the elderly adult end. And those are individuals that have things like dementia or Alzheimer's or other sort of diseases, placing them in these sort of memory care high risk units in these residential areas. And once again, we're seeing this sort of lack of anxious support. I mean, if there's like just the nature of these sort of illnesses and cognitive diseases like dementia will cause someone to be incredibly anxious, but there's nothing really physical, drug-free to kind of get after that root sense. It's more so a very severe and final approach to helping these individuals. But at that point, one may argue it's too late and you get the bad side effects of these medications. And it's like this sort of cycle that will never end. So we really need to look at more preventative strategies as early as you can make them. So moving into a little broader, simplistic view of what anxiety and stress actually is without going into too much detail, the best way to put it is it's your fight or flight response in a modern world gone wrong. So in my opinion, it's one of the greatest evolutionary disadvantages of humans is this sort of anxiety. And that's coming from our sort of prehistoric idea of a fight or flight. So when someone's driving a bus at you, either you fight the bus or you move out of the way. It's sort of that notion, but when anxiety happens is you're not being hit by a bus. There's nothing physical coming at you. So you're kind of stuck in this almost purgatory-like state where you don't really know if you should run away or fight it because there's nothing really physical danger against you, like giving a presentation for your job or just even giving advice to somebody. All these things can sort of bring anxiety and stress to a new level, but your body doesn't really know how to do it, and it responds in a physical way where it makes you feel pretty terrible if you've ever been in an anxious situation, which I'm sure everybody in this conference has, where it's sort of this, your body's doing these physiological modes and releasing chemicals and all these things ready for that fight or flight, but there's nowhere to really put it because there's no real danger. So now I'm going to move into a little bit about some sort of tactics to remediate those symptoms and allow for a better quality of life, and even allow individuals to receive better therapy as sort of a complementary resource to talk therapy and other psychiatric offerings. So first, the stuffed animal Turbobo weighs about 5 pounds. Now, there's a lot of research behind weighted aspects, and I tend to be a big supporter of it. The idea behind the weight is it reduces cortisol levels in the human body, thereby sort of putting that autonomic nervous system into rest mode, and then releasing feel-good chemicals like dopamine, all in the same process, just by putting a little bit of weight. Now, this can be a pile of books on your lap, or it could be a weighted stuffed animal or a weighted blanket when you're sleeping, but it's sort of this simple idea of weight, just putting pressure on your body, on your chest, somehow reduces your heart rate and blood pressure. And that's an incredible feat that there's many drugs on the market for, but there's also this simple, sort of less pervasive method to get that same kind of calming reaction. Now, the next feature in Turbobo is a removable heating/cooling gel pack in its ears. Both of its ears have zippered pockets for inserts that are more tailored to what an individual is specifically looking for. So, for example, if you put an ice pack in the ear and then you then put the ear on your vagus nerve on your forehead, there's a credible amount of science, and I honestly believe it because I experienced the same thing when it's something called a dive response, which is if you ever jumped in a cold pool or a cold shower or just held an ice cube in your hand, your body will immediately be distracted from whatever it was thinking before because it has this new sense, it's overwhelming, and it causes your brain to completely flip switches on what it's thinking about. So, and when talking about anxiety, that's exactly a very effective strategy because anxiety is often overthinking something or can't get something out of your head and really stressed about how you're going to do with it, what's going to happen. But if you have, let's say, an ice cube, you get that sort of reset switch almost, where it sort of pulls your brain in a distraction mode from what was causing you that physical anxiety and allows you to take a little bit of a step back to use logical reasoning to get through your issue, as opposed to being frozen in this sort of purgatory anxious freeze that I know so many people feel every day. And a little more about the cooling and the ice is it pulls blood out of non-essential organs into essential organs. So it also reduces your heart rate. So it really has that sort of physical relief of those symptoms. And like I said, that can be anything from holding an ice cube to jumping in a cold lake. But just sort of that different kind of temperature change has really shown to kind of reduce symptoms to allow somebody to actually think logically and not in that freeze. Moving on, it has a fidget tail and a Velcro tactile patch under its ear. So two very different tactile senses. Now, in general, for a tactile to be effective, again, I'm going to keep going back to the sort of fight or flight response. When your body sort of is thinking, I need to prepare, it's releasing stress hormones. Stress hormones cause muscles to tense and get ready to do immediate physical exertion because you might have to run away, like I said in the prehistoric example. But if, again, when there's no physical threat, you're just getting tense muscles from stress and you're kind of freezing up physically. So if there's some way to sort of, I want to say, regulate that sort of feeling of need to use muscle, you need to use strength to sort of get those hormones released and kind of flush out of your system, sort of fidgets like a beaded tail where you just move things in your hand, or a rough Velcro patch, which is very abrasive, which is a different type of tactile sense. It's something to regulate that sort of anxious fidgeting that I know so many people have struggled with, especially kids, especially elderly adults, especially those who are in the greatest need. And finally, it has a customizable aromatherapy insert. So now we're targeting the olfactory senses in the human body. So what that is, it's about a little circle that you put some essential oil on, let's say lavender or eucalyptus, for example, and you put that in its ear insert again. And now you have something that's releasing these feel-good chemicals into your limbic system, which is your emotional part of your brain, which helps regulate and release neurochemicals that, for example, will lower your heart rate. Just by smelling something from an essential oil, you can physically lower your heart rate just by getting that limbic system. Now, there's, again, research on it, but there is from individuals who've used it, sort of using that as a therapy aspect to sort of have an alternative, yet again, to these more pervasive strategies. So sort of what makes this guy your little best resource and is it encompasses all 5 of these kind of ideas into a hidden stuffed animal to kind of get rid of that stigma, take away the need for feeling worried about getting a mental health support for it's just a stuffed animal. Everybody gets a stuffed animal. So there's no real change in somebody's life as a result of this. And it sort of has the idea where you can use all these functions at once. And that's something that is a very valuable resource in a therapy setting, for example, how so many psychiatric offices in my tri-state area have used this, and especially with new patients, kids, even teenagers, and they say, and it's a perfect opening for their meeting. So they have them sitting on their lap, they're fidgeting while they're talking, they're immediately pulled out of this sort of defensive mode when meeting a new client. So it really decreases the time of care and increases the quality of care for every psychiatrist, which is helping to combat this issue of a shortage of psychiatrists. Because if you can have a psychiatric professional have more therapy sessions in one day than they currently have because the patients are feeling more secure from an earlier state, you can therefore expand your reach and bring in new clients and help more people along the way. And that's what has been the data so far from these different psychiatrists and how from the day one of a new client coming in, especially a child, they sit on the chair, you're in front of a brand new professional, you want to build a relationship, what better way than to start with sort of an anxiety-reducing stuffed animal that the patient doesn't even know is physically helping their symptoms. And that immediately has been reported to open up conversations a lot quicker, almost from within the first 5 to 10 minutes on from the reports. And everyone is sort of getting better client care, and physicians are doing a better job and lowering the time it takes them to do it. So now, in the last 3 months, I conducted a pilot study in my tri-state area around New York, which predominantly started in schools and classrooms. There's no better group or cluster sample than a school because there are so many kids and they're all in the same stressful environment, which requires doing new things, schoolwork, social interactions, dealing with a loss, for example. You kind of get every sort of cause of anxiety in a school just because of how diverse the populations are. Now, this is some data reported from the study. There were 138 participants in classrooms across 5 different public school districts in the New York tri-state area. Now, let's look at these numbers a little bit. They were all of them after this sort of trial period were given a survey, and they were supposed to report what they saw in their classroom and something like a Turbobo, how effective was it? So we start with this one. Did Turbobo make your job as a teacher easier in the classroom? I like to point out that the questions, the answer possibilities were yes, no, and a little bit. There was no little bit. There was almost 90% said yes and 10% said no. Now that's interesting because if you're a teacher and your job is to maintain collectivity when learning, if you're a psychiatric professional in a private practice, your job is to kind of keep the student focused and make your job easier in connecting, then that's incredible data to show the effectiveness and how widely adopted it was. Now you move on to the next one. Did you find your students using Turbobo while doing schoolwork improve their productivity and quality of work? Again, the answers were yes, somewhat, no, not really, definitely not. So we have a breakdown here of there were no definitely nots. So nobody said absolutely not. We had 30% say not really, but then we saw almost greater than 2/3 of participants had yes to a degree, that their quality and productivity from a student in a working environment actually increased because anxiety and stress were simply reduced. Their symptoms were reduced, allowing them to focus more from a logical point of view and outlook, as opposed to being sort of stressed that I don't know how to do this math problem, so I'm not going to do it. Versus, okay, I'm not really as stressed. Let me try to use my teachings and learn from it. So I think this is probably the best data I received, which was that there's actually a quality of work improvement, which is phenomenal. And moving on, how would you rate Thoreau's impact on the overall classroom environment? Again, the answers possibilities were positive, neutral, negative. Not one of the 138 separate staff members said negative. Only less than 10% said neutral, and 91% said positive. And this is the same sort of idea of this one, where even the people who said my job wasn't easier, they're still saying it's still a positive interaction or neutral, but it's certainly not a detriment. And I'd like to, one thing I forgot to mention were the participants in this study range from school counselors, psychiatrists, social workers, teachers, general ed teachers, special education teachers. So there's really a wide breadth of different types of individuals and the sort of students and clients that they serve. And this is what this data is comprised of. And now moving on, we have, would you want to keep Thoreau in your classroom permanently? We have over 80% saying yes, and 10% saying maybe. Again, 0 no's. This is what was definitely surprising from this piloting, was that there really wasn't somebody who said, this is negative and not for me. The worst response you got, and it was a very low percentage at that, was a maybe. So I think that's also encouraging data on how these sort of symptoms reduce anxiety in a child or specifically. And then would you recommend Thoreau to your other teachers or parents for their kids? Again, yes, maybe, no. There were no no's, and it was about 95% said yes, and the other 5% said no. So these are professionals in different areas of education, psychiatry, social work, like I mentioned before, and they are saying, I want to recommend this to somebody else, meaning that there is an impact on the anxiety and stress from using these simple, simplistic ways of physical symptom relief. So it really supports this claim that it's really, you really don't need anything drug related or anything pervasive for stress and anxiety to begin with, at least, because it seems like something as simple as a therapeutic stuffed animal is actually improving quality of work, student engagement, making teachers' lives and psychiatrists' lives easier. And it's before you even get into this sort of reactionary mode. We're only in prevention right now. So it's really cool to see the prevention benefits of using it in that way, as opposed to waiting until some may say it's too late and there's just too much anxiety to really combat in an effective short way. And then another thing that we've kind of sort of started with this business is to sort of different social book therapy and DBT applications. So on a more clinical approach to using something physical like this with sensory tools, you have different sort of social books on things that cause quite a bit of anxiety in kids. But most importantly, we have a DBT curriculum around it. So I'm sure many of you are familiar with DBT and the research behind it and how clinical it is to show improvement in sort of psychiatric care. And it's something that I've looked into and researched and partnered with many psychiatrists and DBT specialists to develop. And it's sort of found this sort of need and sort of gap for something simplistic to use that everybody can use. So to kind of streamline the sort of efforts around it. So chapter 1, for example, is Mindful Adventures with Turbobo, A Child's Path to Mindfulness. And this is using the WHAT skills to kind of break down a student's environment to observe, describe, and participate in a kid-friendly way. Again, as a preventionary tool to really help kids struggling with anxiety and stress before needing severe care in the future. And this is applicable to general students and all students. I like to point out that the first place Turbobo was piloted was in a DBT center and an autism residential institution. So probably the best demographic that would have the most sensory needs or requirements got to experience it first. And they showed incredibly astounding results, which is why I looked into pursuing this as sort of a resource to continue to help kids. And then moving on. So where has Turbobo been effectively used so far? So we saw that the data from the school districts and classrooms, psychiatric offices are using them to increase quality of care as well as increase insurance rates. I'm not sure how it is on the global platform, but in the US, the quality of care is directly associated with a star rating, for example. And this is true for hospitals and private psychiatric offices, in which case it means how many visits did the client come to you for, how long did it take you to treat them, and did they come back in the next 6 months, for example, or a short time frame after your care has completed. And the better those statistics are, the actual more money and funding from insurance that provider is obligated to get. So it's a very interesting dynamic on how there's an incentive to increase quality of care in a faster, more productive way that's benefiting everyone in the US. So it's definitely an interesting proposition. Then moving on to autism and related institutions like those DBT centers, different sort of residential halls where they actually use it throughout the day. They use it to go to sleep. They use it to sort of do their chores or something along that line. Anything with really stress and anxiety to bring it down to a point of manageability. And then in conjunction with professional psychiatric help or a professional sitting down with them, they can really get those good feelings of support using this sort of physical product as an anchor of sorts to open the door. Then we move into elderly centers, memory care units. This is a picture from one of those units and how it's sort of, it was described as an elderly individual with dementia said, it's almost like I'm holding my grandchild. Now, of course, that'll be different from everybody who uses it, but it's sort of interesting to see how these individuals who are pretty much on their own in these foreign residential halls, not their own homes, are having a sort of relief from something as simple with the psychiatric clinical therapeutic modes such as Turbobo is actually making them feel more at home and more in line with their family and reducing in stress and anxiety. So the benefits and data are clearly there from something like this. It's exactly something that kind of combines three senses, olfactory, vision, touch, into something that you can use without shame because it doesn't look like anything pervasive. And it's really incredible to see the results so far. And then finally, one are hospitals. So there's a whole line of child life specialists, especially in the US, where at every single hospital, there are dedicated social work professionals who are there to reduce anxiety of a child before a surgery. And their job is quite literally to remediate their symptoms before so they feel more comforting and less complications as a result of different physiological responses to anxiety from the surgery. So it's actually safer for the patient as well as making their experience a little better. And this is something that is relatively new as an avenue for Turbobo, but the data so far has shown that, especially in geriatric units as well, but with children, they're actually enjoying their time leading up to the surgery as opposed to as shown by a decrease in anxious related incidents from these children ahead of time. And then in the geriatric units, there's a really interesting sort of struggle in the US where it's a lot of elderly adults go to an emergency room for little to no actual physical troubles, but rather to find companionship, to sort of combat isolationism and to sort of kind of remediate stress and anxiety of being alone. And then this is something that's being used right now in testing to see if it's something that they can take home and therefore prevent them from coming back to a hospital and using unnecessary resources just to find companionship, as this is something that can help sort of fill that sort of need without making it too cost prohibitive. So yeah, thank you. That's sort of an overview of anxiety in simplistic terms. I sort of used my creation to kind of show the data behind using these things together and how effective it is. This can relate to a number of different industries, and it's really a good alternative if you're looking for more preventative manner. It is totally fit for reactionary, as I mentioned with the DBT centers, and also high-risk institutions who did use it as reactionary and found it effective, but the greatest use of it is preventative, and that's something that I think as an industry, that's a shift that needs to get moving, is less focus on reactionary and pervasive drug use to reduce these sort of symptoms through medical means or supplements that aren't fully cleared by the FDA because they can't be and potentially harmful in conjunction with other sort of things. So it's just a really dangerous space. And it seems there's a huge focus on reactionary, but not much on preventionary. So this is sort of the way of showing that preventionary has shown results in increasing the quality of care and quality of life for kids, especially elderly adults, and sort of using it in that sort of manner. So please don't hesitate to reach out. My email's here, website's here as well if you want to check it out. But yeah, I'm happy to see how it can be of any assistance.
That was great. Thank you so much, Mr. Ryan, for introducing this cute plushie or Turbobo with us, and whom I would like to call a scientifically smart plushie. That's what I'm naming it right now. Yeah.
Good
So
name.
yeah, and also the statistics you have shown, it was great. 90% positive results. Wow, that was really great. And there was something which was going around in my brain. I'm sorry if I missed it by any means. I just wanted to know, where did this name Turbobo came up in your mind for this?
So I have a personal Jack Russell Terrier called Turbo, and
Oh,
a lot of kids call their stuffed animal Bobos. So kind of make him, and this is actually his coat, this sort of makeshift heart on his side is the actual coat of my Jack Russell. So that's sort of where the name Turbobo comes from.
that's nice. You just combined the names.
Yeah, exactly.
Great, great idea, I must say. And there's one more thing that I'm sure so many people must be looking forward to get a hand on it. So if you don't mind, can you please share the links or something where we can go and buy it? I'm sure so many people must be looking forward to it.
Yeah, so this is the website. It's just www.turbobo.co. You
Okay.
can order all from there. There is international shipping, and if there's anything like a bulk order, any inquiry about it, this is my email to reach out.
So is it available in India as well for shipping for
Yeah,
India?
yeah. It's every through DHL.
That's great. Thank you so much.
Yeah.
So let me call up if you are having any questions, anything people would like to know more about Turbobo. As I could see so many words of appreciation for Turbobo already on LinkedIn.
That's great.
Anything you would like to discuss, everyone?
Hi, everybody. Thank you for your patience. I just had to let the other group know that we were late here. And thank you also to Ryan for such a great presentation and also for allowing me to not get much later than where we are now. So again, thank you again to Olsias and to Professor Mohamed. Really, really interesting hearing some alternative solutions to depression and anxiety. And I do have a lot of questions for you, Ryan, but I'm going to find you afterwards and possibly network a little bit on how we can support each other and work together in different ways to present more innovative solutions and non-invasive approaches for depression and anxiety. And so that's pretty much where I'm coming from, mainly because I stumbled upon rhythm and drumming myself. Having grown up in Africa, I was born in Zimbabwe, and I grew up in South Africa at the time of great political
transformation. And there were some very interesting people coming from West Africa into the country that had this very powerful skill of drumming. And I remember being totally transfixed when I saw a really highly capable drummer solo improvise right before my eyes, and he lit up like fireworks. I've never seen anybody feel so joyful, so enthralled, and so excited by this complex arrangement of sound that was trickling or dripping out of his fingers. I remember thinking, wow, this is a very amazing level of skill. And also, as I was studying psychology at the time, I became quite aware in that moment of the depth of his concentration. And since those days, 25 years later, I've been practicing as a clinical psychologist, and then became a drummer and went much deeper into this topic and started finding it quite interesting that a lot of young boys actually were quite drawn to the drum as a fun tool to play with. And there was some very interesting new research starting to develop on how we use music for therapeutic effect and how rhythm is affecting the brain. But it wasn't until 20 years later now really that we have real neuroscience on a very specific type of scientific phenomenon called entrainment, and how that actually, you could say, manipulates in the positive sense the brainwave electricity to actually calm and soothe the wave of electricity moving through the brain. So I'm going to present to you some of that tonight. I just have to figure out quickly how to mute my other Zoom, since I think I'm just going to have to come out of there. Okay, so we have a presentation here on Zoom where I'm going to share with you a PowerPoint that, if you have seen me present before, you might have seen some of this content, but I have actually made it a little different to you. Just I have permission to share, correct? Gazala, you have it okay for me to share there? Okay, so here we go. Let's just make a real start for this presentation to say that we're talking about something called rhythmic entrainment. And I have an article on LinkedIn where I actually just describe this in detail, called Rhythmic Sound Energy Medicine. And I wanted to send that link to you in the chat. I will do so, and also will send to you a list of resources by a very famous now, Dr. Barry Bittman is his name, one of the people who began some of this deeper research on the way to actually understand how drumming is helping to alleviate anxiety and lower depression. And he did a lot of his research on cancer patients before they went into chemotherapy, and in fact managed to set up drum circles in some hospitals, did a lot of the research, and managed to explain a lot to us over the years about, real clinical trials and studies that explained this very interesting way that drumming and rhythm and sound, organized sound, actually affects the nervous system. But I want to start the story just sharing with you a little bit about an ancient indigenous type medicine man of old times in many different cultures all around the world. There were these very nature-based healers, you could say, or people that were thought to communicate with nature in certain ways. And this is where a lot of the kind of wild idea of drumming and just being out of control comes from, because these were in many different kind of spiritual traditions, people that had a very specific use of the drum. And it's said that the specific frequency of rhythm that they would be creating was actually a type of music medicine. And so I represent a lot of the work from an institute in America called the strong institute, and they have done a lot of the research on what is called rhythmic entrainment, which explains, as its precursor, as its original idea, the tradition of what is now called shamanic drumming. And it's over 30,000 years old, this phenomenon. We've had, archives of this in many, many different cultural groups, in many different times. Aeons ago, we have seen the drum was in use as a ceremonial tool, as a healing tool. And only now can we really study and understand what is it actually doing to the brain. And so it's considered one of the oldest organizing systems that communities would use. And in these specific types of drumming traditions, they would actually create repetitive rhythms played between 3 to 4 beats per second. And this is where it becomes very scientifically significant, because if you're stimulating the brain with 3 to 4 stimuli, points of attention in one actual second, you are bringing a very detailed level of concentration into the brain, if you can actually manage to get the brain to concentrate on that split attention in that second. And for many of us, we might miss it, but if it's pervasive and repetitive and very intentional, it does definitely start to entrain the brain. And this is actually something that we've noticed is having a very specific effect on the nervous system. So when you're doing this kind of 3 to 4 beats per second, from anything over 10 minutes to well over an hour, this organized sound is actually inducing what we call a trance or a peak state. This is where the brainwave frequency, the sound waves, is affecting the brain through a process called auditory driving, affecting the focus and the concentration of the brain. And it can actually be accompanied by certain visualizations, which certain traditions would use. It could be having certain intention. It could have a dance attached to it. It could have a whole mythology, a whole kind of ideology related to it. But in fact, its primary effect is that it does start to affect the physical and physiological level of the body-mind system, as well as the psychological, emotional. We also have then this phenomenon of actually helping certain illnesses to reduce in their symptomology. It's not a very easy thing to be practicing. 3 to 4 beats per second is pretty fast. It takes high levels of skill. That's why watching very accomplished musicians also gives us a certain kind of psychological effect. But here we're talking about a physiological one, because it's a central nervous system response that we start to see in many of the research studies. So rhythm healing, however, depends on the symptoms or the cause of the illness that we are addressing. So we can't just say that we cure a disease or an illness by playing a drum, but we can see a reduction in symptoms. But this definitely depends on how it's used, what's caused the illness, and it's definitely said to then treat a variety of psychological conditions. And of course, we're now going to see some of that research. So just reminding you that the whole concept that we're talking about here is actually related to some research that started off by a Dutch scientist called Christian Huygens in 1665, who would look at the very specific way that the pendulum of those old clocks were working. And he found that 2 of them on a wall near each other that started maybe at different times, after a while would start to actually tick in unison. This is pointing to the very interesting phenomenon of entrainment, which has been found to actually be a universal force in nature and will act on any 2 or more vibrating bodies as long as they have similar rhythmic cycles. So when we're drumming, we start to see that the brain is one of those objects, and the rhythmic sound is one of those other objects that then start to synchronize given very specific intervals and frequency of beats. I'm going to leave it there, otherwise it gets a little bit more complicated. I just want to give you a brief historical account of how this initial instrument that we call the drum nowadays was actually in the hands of women. In old mythological sightings, we have it in the hands of various goddesses. images and statuettes and emblems and certain totems that were used for certain burial, pointing to pagan religion, indigenous cultures from way back 10,000 BC. And in fact, the very first one was in a place discovered near what we now call Turkey. Katsalyuk is actually the name of the place of the very first drum. So we know that women were using it to create some specific ceremony. And now we know enough from various historians who've actually studied that to tell us that they were actually using the drum to go into very specific levels of synchronization and entrainment as a group of women. They would also have some association to the 27-day moon cycle, which is the cycle of menstruation. And women would use the drum to regulate their emotional bodies and their level of concentration before going and giving prayer or thanks to the fertility goddess. And there are many different traditions from Lebanon to Iran to ancient Persia, Pakistan, India, Iraq, Kazakhstan, Africa, Libya, Algeria, Egypt, Greece, Cyprus, Ireland, where this was happening in the whole Mesopotamia region. Now, why and what does this actually do? Why are these traditions of drumming so long-standing, and why do we still have a lot of confusion about it? Well, it has been part of an ancient system of community building, of creating synchronized system of sound and regulation of the mind-body system. And so we see now that there's a nervous system that's connected to the brain. And as we know, we are not just our mind, we are not just our emotions, and we are not just our body. We are a unison, a combination of all three. And with drumming, we begin to see that it actually works through the auditory system, driving the sound in through the ears. Eventually, the brain cannot concentrate on thinking and listening, so it has to choose one of them. And after 10 minutes, interestingly enough, if you keep the rhythm going, the drum is going to win. It actually convinces the brain to focus on it, and the rhythm is becoming so repetitive and consistent that it actually starts to entrain the brain to move along with it and synchronize with it. This, in effect, starts to teach the nervous system how to regulate. And we have now a whole new system with the Strong Institute that we've been testing for many years myself, but also in very formal studies, as in with the Autistic Association of America many years back. It's been tested on anxiety, special needs, autism specifically, anxiety very comprehensively, and also chronic pain. Those were the initial studies. But what I want to point to today is just really a bit more about what is happening in the brain when we are in depression or anxiety. There are many ways to understand this. I want to give you one that I think is quite simple, and we have great professionals in the plethora of teachers and trainers and professors and doctors on the Alceus platform to provide many different ways of understanding the neurological profile of certain symptoms. But for us as those interested in looking at non-invasive techniques, we focus on this specific one, that when the brain is in a depressive cycle and or an anxiety cycle, there tends to be quite a strong level of beta brainwave frequency, meaning the people who start to have a lot of that breakdown in self-image, very depressive profile, chronic mood disorder, no matter the diagnosis, tend to have a very repetitive negative cycle of thinking. And that can be either rapid, it can be slowed up, but certainly we see a lot more resistance or inability even to be able to slow down the brainwave. So they can't relax very easily. They might be very agitated. They might have, lots of inner thoughts, an inner critic that's very chronic. We know a lot of people that have depression might come from traumatic backgrounds. They might have had unprocessed childhood trauma. They might have an actual traumatic event in their life, like an accident, the loss of someone, which is going to stir up a whole level of chaos and unrest in the nervous system, again, pointing to the fact that there's going to be a lot of active thinking or active worry. And what we're doing when we're looking at drumming as a way of lowering anxiety is we're actually driving the rhythm, as we said, 3 to 4 beats per second. And if we get very, very progressed, we can move it to 6 and 8 beats per second, which is very indicative for what we call the autistic spectrum. And the ADD spectrum requires 8 beats per second because it reaches homeostasis so easily. So what we see is if we produce enough alpha, which we can do with the drum and training with the brain, we start to teach the nervous system every night for 30 minutes ways of learning how to go into alpha at a time in your life, depression or anxious type symptoms, where it's very difficult to go into alpha. As the professor was mentioning, sleep is a really big issue. Ryan was pointing to the weight on the body, which I think is so wonderful that you point to that, because it's very true. In fact, in a lot of yoga traditions, not many teachers know this or say it, but I've heard a few over the years who've actually pointed to that. If you are very extroverted, or you have a very agitated profile, or you're very busy or very intense as a person, it's very good to use more weight on the body, because it actually presses on to the nervous system and sends a certain kind of pressure, which is sometimes like the element of wood. If we press, like I'm a massage therapist as well, so I understand very much how massage is supporting the body to learn to release. So weight can do the same thing. And it's very true that when we apply slower, when we have slower brainwave frequencies, like we do when we're in alpha brainwave frequency, we have a different way of releasing. And there are definitely these levels of effect happening after exposure to various types of sound from the drum. Now, a study by the neurologist Barry Bittman that I mentioned before found that group drumming sessions actually do lead to increased alpha brainwave in participants. It's now a known fact. People go drumming, people learn to drum, people generally like to study a musical instrument because they know it's relaxing. There's quite a big difference between the percussion-based style of relaxation and general instruments. All instruments can help take you to alpha. Drumming can take you a little deeper into other states that we call theta brainwave frequency, because they have a bit more trance-inducing effect. And then I'll point to some more detail just now as we move on to the psychosocial benefits of drumming, which isn't always so easy to achieve if you're not a trained musician, whereas with drumming, it's a little easier to learn the instruments, so you can reach these kind of community-based experiences where there's a common intention amongst the group. So given that drumming is producing alpha brainwave, it suggests that drumming can then help to promote a more relaxed and reduced stress level. And this is indeed what we are now talking about, because many neurological issues will present with less ability to regulate emotions, much more pronounced intense emotion and or loss of emotion, numbness, no endorphins running, not much reason to feel happy about things, can't really access the positive sense of self, don't know why I should be around, maybe don't feel very grateful, have lost the sense of hope and desire for living. And that does compress our system into a much more constricted way of operating. So we know that if we can produce alpha, we can get the brain to focus and relax at the same time. Given enough of that, we can actually start to induce more positive experiences. This is all because there's a psychosocial factor here in depression and anxiety. And I don't know if you'll agree with me, but we've seen an increase now in anxiety in women. I don't know if you're aware of this, much more substance abuse by women. A glass of wine at the end of the day is more common now than it ever was for women. We've also seen an increase in anxiety levels in women post-COVID. So we know that the picture of anxiety in general is changing. Certainly in anxiety, we can see that. We've got a lot more depression and anxiety happening in young people. I don't have all the stats with me, but there's a lot of conferencing around, the disillusionment of the future, the kind of uncertainty of employability in the future, a world at war. We've just come out of a deep recovery from an existential crisis, we say in psychological terms, of not knowing, where we stand in terms of our health and our access to healthcare and our future health opportunities because of what we went through during COVID. So we could certainly say our sense of hope and relaxation in general is compromised as a society right now. And so it makes a lot of sense that we need to be looking more also at psychosocial factors, which have always been contributory to depression and anxiety, and will continue to be and maybe exacerbate over time, because depression and anxiety have within them a certain kind of crisis of belonging and a crisis of self-image. Certainly in my work over the years, I've seen many different variations of depression, anxiety, as the professor mentioned, comorbid with physiological, medical, or psychological factors like PTSD type depression or anxiety response is quite different to someone who's had prolonged trauma all their life and maybe has a bipolar disorder presenting with some psychosis. So we can see very different presentations of anxiety and depression, but I named on this slide some factors I think are very important to keep in mind that tend to pop up more often than not when it comes to looking at what does depression and anxiety really circle around. What are the themes? One is identity. Who am I? Why do I exist? What's positive about me? Because we discussed that sense of inner critique and sense of judgment that comes into the mind and starts to present much more this kind of fast thinking or negative thinking cycle. And I tend to find a lot has to do with a sense of belonging. And I want to address that when it comes to the sense of community that we're losing in our society, which is why we're seeing, I think, a lot more questions about identity and our sense of belonging, our sense of cohesion and togetherness. Feelings of happiness are obviously escaping us when we feel depressed or anxious. We're not able to access the positive side of life, or to remember the positive side of life, or to think about the future as positive. And that really points to why, again, when I come back to this slide, drumming has a remedial effect, a very important sense of positivity can be generated by moving into rhythmic sound. Certainly when you start to play the drum, because you start to drive that brainwave frequency into focused, concentrated, organized sound. We heard from the professor that structure is very important for depression. And we know that when we're drumming, or when we've seen groups of people learn to coordinate hand, body, mind, brain, concentration. I've had psychiatrists, when I first started doing it at certain hospitals back in South Africa, talk about it as a physical therapy, and very much so it is. You're using the whole hand, and if you know a little bit about the energy system, according to the yogic tradition, again, in India, we know that the palms are actually connected to the heart, anahata chakra or energy system. So when we are massaging, or when we are touching or hugging, or when we are, physically involved with something, or when we are drumming, we are stimulating the heart center, and in fact, the whole breathing diaphragm area. It's very hard to drum if you're not breathing correctly. So when you change the oxygenation of the body-mind system, and you're using the energy coming through the palms of the hand and massaging that in and out of the body, you create something called a biofeedback loop. And that in itself starts to press the sound back into your brain. You keep trying to produce the sound, and you end up in a very cohesive, organized sound system, synchronized space. It's called entrainment, like we said before, when you're just listening to it. But when you're actively producing it, you are entrained and also in a biofeedback loop. If you start to use certain rhythms equally on both sides of the body, which was where my fascination came in, and wanted to do a PhD on this, maybe I'll still get to it, you can actually go into what's called bilateral symmetry. And our brains automatically do that when we sleep. We go into bilateral symmetry in the body, and this helps us actually regulate the nervous system. But if you're not sleeping so well, or you don't get very much of that, or let's say you're just extra tired, or you have a depressive symptomology or an anxiety response to something that's happening in your life, you're also not getting that. And of course, we all have many different factors affecting us. So we're not all getting the kind of restorative effects of our bodies that's possible. And so this is why even very specific rhythms can take us into very deep states of relaxation and symmetry within the body, which is a profound experience, because once you regulate stimuli on the right and left hemispheres, you can go into what's something called hemispheric synchrony. And this is where it's almost like a state of meditation, or if you've heard about the state of flow, it's a way for us to actually go into a very harmonized space where we go beyond the world of right and wrong, and the brain starts to recalibrate into a space of equanimity, what we can get sometimes when we're in high states of meditation. This has been researched, of course, over and over in many different ways, but with drumming, we just know some of the basic levels of benefit, but we also know with these structured rhythms, which was what my study was going to be about, that are using both right and left equally, we can create very specific states of harmony. We know that lifestyle factors affect depression and anxiety. And of course, I mentioned this, alluded to it before, the sense of community is very much at a loss for people that are depressed. They isolate, they don't want to be socially connected. There's a fear of judgment, stigma, as we mentioned. And I have some great mentors and teachers who are not in any way clinically trained, but are spiritually interested in helping people that have depression. And I've been very intrigued by the fact that they explain depression as a lack of deepening, meaning they have explained that sometimes depression can be about a need for us to go deeper into ourselves, to know what really matters to us, and that depression somehow forces you on a psychotherapeutic level to really take a look at why do you feel ignored? What social skills do you need to build to feel part of society? What is more important to you? What is your purpose for being alive? You know, what's your sense of meaning? How will you create that? What career do you really want to follow? And so we do have a psychotherapeutic job to do when people are depressed and or anxious. We need to look at how they are learning to regulate, which is the most important factor, I think, that we are really needing to teach, learn, and educate ourselves in and each other when it comes to general healthy functioning on the planet. The level of emotional management and regulation in the world is very, very minimal. I mean, we can see it by the way our world leaders deal with chronic problems. And we're not surprised that people are now talking so much about emotional intelligence. And depression is, I think, symptomatic of a world that doesn't know how to deal with very difficult feelings and doesn't know how to respect people that are going into an existential inquiry about the deeper meaning of their lives. And of course, yes, when there's medical factors or physiological reasons for the depression, that neurochemical balance does need to be restored, but there's still a piece of emotional work to do. So a quick mention about entrainment. And I mentioned before that we had this reminder of the fact that entrainment is a way where two bodies synchronize, and we do actually have all types of entrainment through even our respiration and heart rate. And we've also got ways of understanding our motor movements can actually then also be entrained by an auditory stimulation. And this is pointing to the fact that our body-mind system can synchronize to a certain kind of stimuli, just like Ryan's example of our body-mind system can respond to a sensory experience in something that emulates a very comfort factor or self-soothing experience, which would, be an animal or a nature-based environment. And so if we could emulate that, we can get the same effects. And in this sense of auditory driving, we know that if we are using these frequencies, we can actually drive the body-mind system into states of greater relaxation and calmness. A quick picture here about the pendulums that help us understand the very way that one ball has a momentum on the other balls that then will resist once there's contact. But then before you know it, they all start to swing in unison, demonstrating quite clearly this power of entrainment. As I mentioned, the alpha brainwaves is when we are focused and relaxed at the same time. And I want to just point to this fact right at the bottom here, which is why I asked the professor more about dopamine. I'm always interested to learn a little bit more about the mechanics of that, because as we all are now, very much using devices. I don't know how many of you, maybe you can put in the chat, are actually noticing people double devicing. And are you perhaps doing that? Because if you are, you want to just take note of how often you're doing it and see if you can be more aware when you're doing it, because in itself, it is a moment of overdrive stimulation for your body mind system. And the fact that we're so tempted to do that, watching TV while being on the phone, for example, or being on the phone and gaming, as another example, is a level of technological stimulation for the brain that we think we can handle. But imagine that over time, your body's going to be so influenced by not just the stimulation, but the LCD light, the technological wave, really preventing you from being able to access your own relaxation states later on, or when you sleep, etc., etc. And of course, now what are you doing online? Are you looking for information? Are you on suspicious sites? Are you interacting with people that maybe have something very unsavory going on? There's lots of ways that we can get into some very increased technological use that's not very healthy for us. And given that we're living in the times that we're in right now, many people have started to show much more neurological disturbance or degeneration than we expected. And there are some great studies that were done during COVID that are pointing to the fact that possibly even COVID had a way of affecting neurological disorders, and made it quite difficult for certain people to follow their normal prognosis for their specific neurological disorder, and that COVID had sometimes even accelerated certain symptoms for people. So that's all pointing to the fact that we have a society around us right now that is actually quite compromised in being able to produce and maintain alpha brainwave frequency. And we heard the professor say something about children. We're seeing depression a lot more there, much more higher ADD cases. Now there's 6 different types of ADD, lots of comorbidity with autism. Autism is on the rise by 50% in the next 10 to 15 years. I heard at a certain conference that was dealing with, a readdressal of autism in general, and what it's actually an indication of in terms of social skill. And what does that mean if we look at the social skills of young people in the future, along with this kind of temptation to spend more time with technology, sort of preventing us from building more human in-person social skill. So I hope I impress upon you now then that those with neurological disorders, those of us on devices, those of us double devicing, are all sitting in a very compromised state of not having enough downtime, not having enough natural alpha brainwave. So we need to look at new ways to produce alpha, which is why I wanted to let you know more about the drumming. Pointing back to this fact again, then, we see a lot more beta when we're in high stimulated states. We're more alert, we're more thinking, we're more in excitement. Be aware, being inspired for too much, or being a high adrenaline junkie, or being, very busy as a person, can also overexpose you to beta brainwave frequencies and make it harder for you to go into this relaxed stage, which is very important for you to regulate your emotions, to really reflect on yourself and your life. Many, many things we need to do when we are in alpha. I'm not going to go too much in detail here. If you do want to know more about the research studies, I've actually prepared a post for you to go and have a look at, and I've got all the links there so you can go and do some study. I'll just review them with us here, but here's some studies that were done on anxiety-based behaviors in autism. Clinical studies showing vast reductions, an average frequency of 86.4% after being exposed to very specific rhythms with this entrainment factor that we talked about, that had a residual calming effect on the overall behavior. And the average anxiety, at 82 out of 100 of that point scale reduced down to 38. This is standing for the REI rhythms, rhythmic entrainment intervention rhythms. So these are specific rhythms that have been researched over time to actually do that 3 or 4 beats per second, and sometimes 6 beats per second, which is like a roll. If you can hear that, that's a rhythm that has this continuous subtle, very low volume frequency of beats with very specific ambient waves, sound on top of it, is starting to slow down the brainwave frequencies. We see also reducing effects in anxiety, general anxiety with children, and aggressive behavior. Also helps to contain aggression. This is the article I mentioned. I talked about rhythmic sound energy medicine because I want to respect the fact that there is something happening in the resonant field around the body as well when you create a lot of vibration. Remember, I told you about my friend who I saw drumming from West Africa. That person is creating like a fireworks display of some kind that is vibrational. What does it mean? The electromagnetic field around his body is getting activated with all that sound, changing the molecules of the air around him. So I know it's sometimes considered a dirty word in medical circles, but I use it proudly because I do like Einstein, who said the future of medicine will be energy medicine. We need to start thinking about more holistic, integrative approaches to body-mind solutions and look at ways where we do not just see ourselves as physical matter. We are not just physical matter. We have thoughts affecting our matter. We have emotional residue that we can't see, but definitely affects the profile of a person. We can study it on the hormonal level. We can study it on the feeling level. You feel differently around someone who's angry versus someone who's happy. And so whether we see it or not, we are using that word energy to talk about what's unseen, perhaps. So with anxiety, we see a reduction in emotional outbursts, generalized anxiety when we use these REI type rhythms, self-stimulatory behavior. At times someone with a lot of anxiety can do very repetitive activities. Aggressive behavior reduces, and sensitivity to sound or light also reduces. Just a quick recap. I've done the REI and I use it with a lot of clients who prefer not to have something invasive or have tried chemical treatment or prefer not to use it, or it's not working on them, or they're afraid of that, or the stigma of that, and or have had the experience of someone else in their society or in their community being over-medicated and then have some kind of resistance as well to going through that path. And these are just some examples of different cases that I've treated with REI or drumming in the listening sense, but of course have also taught many people over the last 25 years to drum, to play. And I wanted to just share with you as a last comment here, the article that I think is really worth reading through if you do want to have any more information, because it's pointing to some of the deep science that's been done relatively recently on the spectrum of use, drumming affecting then depression and anxiety. And just to give you a quick idea, this is from the rhythm research. The effect of group empowerment drumming on cognitive performance has been studied specifically in women with fibromyalgia. We heard that there are autoimmune disease etiologies, we could say, for depression and anxiety. It's definitely something I'm very passionate about myself, because I run conferences on integrative health, specifically looking at how to treat depression and anxiety and all the psychosocial factors related to women and their hormonal imbalance. I mean, we know now that infertility, female-based cancers, autoimmune disease, high levels of anxiety, as I've been mentioning, are affecting more women now than ever before. And we have an epidemic of hormone imbalance, which means we will have a lot of mood lability in the future. And we need to have different ways of understanding the female body because of that high emotional amygdala center in the brain, and because women are very emotive. We've only had 50 years pass from when Freud sort of pathologized emotion a lot in women, but women have emotion, and that's very normal for them. So how do we learn about these new autoimmune diseases and how they affect the mood, and what could we be doing to help women regulate more emotionally? So here's a great study by California State University on that topic: immediate effects of group-based wellness drumming on affective states in university students. An interesting study about wellness. The effects of community African drumming on generalized anxiety in adolescents. There've been quite a lot of studies done on teenagers and addiction with drumming, and that's an example of one that looked at the generalized anxiety, which can often be a very strong precursor to drug use and substance abuse. Making music for mental health, how group drumming mediates recovery. So people post chemotherapy, people post rehabilitation, drumming gives that sense of community where everybody's connecting, learning to play the instrument, then producing the endorphins, going into that biofeedback loop that I spoke about to actually produce this very organized, rhythmic, synchronized production and a state of harmony that goes in and around your whole cognitive process and your production of endorphins. So we can see that for recovery, that could be a very socially adaptive way of building trust with a social group again, but then doing it in a therapeutic way. African drumming, a holistic approach to reducing stress and improvising and improving health, improving health. And we also have therapeutical potential of a drum and dance ceremony based on the African Ngoma tradition. These are all very specific in the fact that African percussion per se is something that we call polyrhythmic. And polyrhythmic sound has a very specific way of complicating the cognitive process and then intensifying the attention and the concentration levels. So when we talk about African drumming, it's very different to a lot of other rhythm traditions, which is why you might see, I don't know if you've ever witnessed a very professional African drummer, and I think in India we also have the ragas and many different styles of musical sophistication that is running on many layers of accuracy in order to sync up the division of time, the time signatures in very interesting ways. And this is certainly a very highly developed skill. So we should start to, understand the intricacies of that, and that there is, a therapeutical power in that we haven't really understood until now. In fact, even through colonization, there was a lot of judgment about African percussion as just a cacophony of noise. I remember one ethnomusicologist called it that. It was considered very racially intolerant and really uncool, really, that people, from the West could not really understand the layering of that polyrhythmic sound, many rhythms working in unison together. So a highly mathematical formula of how these rhythm frequencies all fit together to create this kind of dissonance through harmony. And this has a very specific effect on the way that we are releasing friction through the nervous system, especially when you're learning to play it, stay in that concentrated sound, and it has a very strong therapeutical effect. The effects of group improvisational music therapy on depression in adolescents and adults with substance abuse, a randomized control trial. And on this, I just want to end off saying that I was most amazed by an MRI study that was done with jazz musicians. And this really speaks to the point. And for a very long time, they couldn't really study the brain in real time. I remember when I was a student, I wanted to, and I was told to wait because there was no technology for it. They could only test the MRI and not have interference from hand drum playing while they would be testing the brain. It would cause too much motor coordination or motor response interruption with the reading of the brainwave activity. Now we do have new systems that can test. And so in this particular study, they took some jazz musicians and they measured their ability to play an organized, orchestrated piece of music in this kind of MRI scan type testing environment. And then they measured the brain when they would play that musical composition and then begin to improvise. And what they found was that when there is a level of improvisational skill on the orchestrated piece, the brain goes into the highest level of activity in any other skill ever measured, which is pointing to a level of musical ability, but also integrated and holistic brainwave, holistic brain activity that was creating some new questions about what we are really capable of doing when it comes to high level of skill. And we call that kind of high performance levels of activity. And so from that study, there were some very interesting suggestions that improvisation through music or sound, but music is a much more tangible way of measuring it, is inviting the brain to start to do things that we can very rarely access, because we do have to have a structure, and then we begin to create within the structure, which means we start to use what we have always thought of as contrary skill sets. So to think logically and feel at the same time is something we can only do in certain higher states, like theta, where I mentioned before. The same with improvisation and logic. So to have a structure of playing and then to be able to improvise, which is what my friend who I told you about at the very beginning from West Africa, his name was Sidi Sangarai, was demonstrating to me at that time. He had the structure of the sound he was learning to play as a drummer, and then he would begin to improvise. And there is a level of brainwave activity that is on this high performance skill level. So in conclusion, then, we can definitely say that we have new and interesting ways of exploring the brain and the body-mind system when it comes to depression and anxiety. We already have some very interesting ways where we can build community. We can use music. We can use creative modalities to lower stress levels. There's loads of evidence on how creativity helps to assist people that have, very stressful lives. You go take a pottery class, you go learn some painting, sit with your kids or your cousins, do some drawing, spend some playtime with them, and then perhaps even, yes, learn a musical instrument. And if you can, consider percussion, because there's something about the way that you are exposing your brain to certain beats that you start to organize, concentrate, develop more alpha, and boost endorphins. I hope this has been helpful. I'm going to look at 2 questions on the box, and I will be very happy to meet you anywhere you like. I'm on a page called Drum Inspire, and I also have put the research there of that article that I wanted to give you access to read. And I will also give you the link for this post that mentions all the research I just went through. If you do want to study this a little bit more, please go ahead and ask me any question you like on LinkedIn anytime. And come and visit. If you're ever in Cyprus, let me know. That's where I am, and I will be in Dubai in May. So if you want to know more about any of that integrative health, do get in touch. I would love to meet with you and get to know more about you and the work you're doing. So for individuals experiencing chronic anxiety, how sustainable is the therapeutic impact of drumming over the long term? Excellent question. Are there guidelines or recommendations for incorporating drumming into a regular self-care routine? Pretty much, if you're drumming, I've seen people improve over 3 months with 1 hour of drumming in a group context once a week. If you can do it more, you do some drumming on your own, you do drumming in a group, try to find a community. There's something about the communal aspect because it creates a sense of ceremony. And this is what we all crave. We need social support. And what's great about drumming is you don't have to tell people you don't feel good, or you're sad, or you're low, or you don't feel, this or that. You just kind of get absorbed in the group space. When you can't find a group, maybe you can look online, find a YouTube video. I have a whole channel. If you want to learn some rhythms there, you're welcome to, get all that for free and just explore. And then just buy anything you can afford and spend some time with that instrument. We do refer to long-term benefits. The reduction of symptoms I talked about from the Rhythmic Entrainment Institute are organized programs of 4 months intervention every night, 30 minutes exposure to specific rhythms, is training the nervous system over time to learn to regulate and integrate the sensory system. Because when we're depressed or anxious, our sensory system is not integrating and it's not regulating. Our nervous system is quite sensitive and dysregulated. So the alpha helps to do that. So it's certainly a long-term benefit, and it would need 4 months. In our cases, we do that entrainment every night, just listening for half an hour, and it's customized for each individual case. You can appreciate if someone has ADD and they've just been in a situation where they maybe have a post-traumatic stress response, they would need a very specific kind of audio. And that's what the Institute is working to test. Over 12 repetitions every 2 weeks, we update the audio, and we see improvements in up to 75% in most cases in reducing the symptoms. We don't cure the condition, we don't cure the disease, we don't solve the illness, we reduce symptoms. That's all we're interested in doing, actually, because we don't want to get into even diagnosis too much. We're looking at symptomology. So frequency, consistency, repetition, and duration of symptoms. We study all that before, over 147 questions. We apply the rhythmic entrainment according to what we've measured, and then we test every 2 weeks, how does behavior change? And what we see is those symptoms reduce by 75% in most cases, sometimes only 50. And in some rare cases, we don't get very good results because we've either got comorbidity with other things, or we've got a complicated picture where someone might be on medicine. And we also sometimes have pre-existing intense influencing factors, like we don't work with psychosis very much because chronic psychosis obviously sometimes has comorbidity, sometimes substance abuse, etc. Yes, it's great to see all these non-pharmaceutical options, because not everybody can respond to that regular dose of medicine. And sometimes people want to feel different as opposed to think they have to drink something to fix themselves. And this is a very important psychological aspect of healing, and also the community that I keep alluding to. It's a very, very powerful variable in healing. Yes, thank you to Yong Lee. He's asking, is this different to music? Yes, we have a very interesting Italian researcher who started off looking at music in general. And and there are many people that have studied music. Pythagoras was a pioneer. There are many people in ancient Persia who studied sound. We have the Sufi tradition, which looks very deeply at how sound emulates the planetary forces. And this kind of spinning that you see in Sufi tradition, the dance to the beat of that frame drum, is a very specific way of changing the circadian rhythm inside the whole energy system. So we know that just general music can have a psychological effect on your mood, but to regulate your nervous system, we find drumming is about bringing stimuli per second into the brain concentration process that is very specific. And this is why we talk about the primordial pulse of the universe, that is actually emulating the primordial pulse that your body in utero was actually responding to. It's fascinating, very interesting stuff to know that our cells are actually generating based on the rhythmic flow from the spinal fluid inside the spinal column of our mothers. So when we are babies in utero, our generation is caused by vibrational impact. So we have a very ingrained ability to heal and to rest and to calm and soothe ourselves through very specific primordial sound. And that's why there are many traditions all around the world that work with sound, dance, music. But there's something about the pulse, something about the vibration that's much more immediate, much more primal, and much more directly driving into the brain because of the frequency that comes from drumming. Unlike playing the drum, some drum sounds, such as a battle drumming, makes people more nervous sometimes. Can you agree? Absolutely. And this has to do with the regulation of that stimuli. So that's what we're testing. As I mentioned before, some people get very unnerved by the rhythmic sound, and that's what we test. So they have a certain sensitivity to that stimuli that maybe is not the case in absolutely everyone. So that's the detail of our analysis. I mean, I work with some children that are highly sensitive, and we have to put much more emphasis on lowering the volume when we do the testing with them. And we still have to find what is the perfect level of stimuli for this young body to regulate its nervous system, because there's a lot of interference and a lot of ways that we get influenced unwillingly by electrical light, by geopathic stress. There's many things affecting our energy and our feelings and our mind and our level of ability. And we have to learn to regulate that. But what happens when a child is not regulating? They're just having temper tantrums all the time. What does it mean? That's what we look at, the nervous system. How is it regulating? So definitely putting on some classical music, normal music will calm you down psychologically, but not neurologically or on the nervous system level long term. Whereas the drumming programs that we've now been working with are working for that specific purpose. I'm working in circadian health, looking at how light impact mood and affective state. It's great to see how many. Yes, wonderful, Chloe. So that's really interesting that you're doing work on that circadian rhythm. Yeah. There's a reason why in India, they even have a whole study called NAD yoga. NAD, the intention is affecting matter. The intention of playing an instrument, the impact of hitting the instrument, and the way that feedback comes back to you is a primordial, profound way of understanding your impacting life. So it's a deep symbolic and profound message in also learning to play percussion, because it's starting to teach you about your own agency. I could go on forever, as you can hear, but I want to hand back to Ghazal. It's been lovely to be with you all tonight. If you want to know anything more, please come and find me. I have to hop off because I do have another training. Thanks so much, Ghazal. I can answer any question and then I'll need to go.
Oh, that's fine. In case we'll be having more questions, Miss Helen, I'll definitely forward the questions to you via mail or on LinkedIn, via WhatsApp, anyway.
Excellent.
As I can see, you are really busy and more works are on the way to you.
Yes.
Thank you so much for joining us today, even though you are so busy. Thank you for taking the time.
Thank you so much to all of you. I'm sure we're all very busy, and I'm very grateful you all chose to spend time here with us all as well. Thank you so much. Thanks, Ghazal, for all the organization. Take care. Bye-bye, everybody.
Thank you so much. All right, everyone. With warm thanks to Miss Helen for explaining the how drumming or the sounds can affect our anxiety levels and help us maintaining our anxiety, and taking up the questions. So let us move forward to the questions, as we are having so many questions and lined up in the chat box and in comment section as well. So I would request to the people who are asking the questions, who are already present in the meeting room right now, please come up and ask your questions. That way it will feel like more like discussion and asking the questions. It will be easier, right? And I can see so many questions from Miss Neha Ghanshani. Can you please come up here in the unmute yourself and or come up on your screen and ask the question?
Hello.
Hello.
Yeah, so my question is to Professor Mohamed.
Yes.
Professor, given the growing interest in the field of psychoneuroimmunology, how are researchers exploring the bidirectional relationship between the human immune system and depression? Like, are there implications for immune modulating interventions in treating depressive disorders?
Yes, there is a bidirectional, definitely by research and evidence, there is a bidirectional model and explanation of depression in from the perspective of immune system. If the immunity is lowered, the patient or the person is more vulnerable for development of depression. And during depression, his immunity also is affected. And there are evidence for interleukin 1, 2, and 6, and other biomarkers of immune system, such as tumor necrosis factor, and brain-derived neurotrophic factors, which are involved in the development of depression. But their use as a sustained biomarkers is not fixed findings in all patients with depression, but there is a strong evidence of the immune system as its relation to mental illness, especially in depression. And the use of immunomodulators might be used in treatment of patients who are complaining from depression, especially those with evidence of biomarkers changes or a comorbid any inflammatory disorders. But the evidence is not duplicated for massive and to be generalized for use for treatment of depression. Okay.
Thank you, Professor. I just have one last question to Professor Mohamed. So
Yep.
it's considering the heritability of depression, to what extent do genetic factors contribute to its onset and progression? Like, are there emergent trends in personalized medicine that leverage genetic information for more targeted interventions?
Again, please, Ghazal, where is it?
Yes, Professor Mohammed.
Where is the question? Can you repeat that again? Excuse me.
Yes, sure. So, like, considering the heritability of depression, to what extent do genetic factors contribute to its onset and progression? Are there any emergent trends in personalized medicine that leverage genetic information for more targeted interventions?
Okay. Depression is not only a gene, it's polymodal genetic expression. Phenotypic expression is the one who is developing now for the understanding of depression. Yet evidence for specific gene loci is not fixed findings in depressed patient. So the research, more research for the finding of specific genes to be correlated with the presence and expression of depression is one of the objectives of the future research. Yet the positive family history of mood disorders is evidenced in patients with depression. It increases the vulnerability of expression of depression in those with positive family history more than the general population, as evidenced by twin studies and adoption studies and SNPs studies of the genes. Thank you.
Thank you, Professor.
Thank you, Ms. Neha, for the question. And let me ask if anybody else is having question from Professor Mohamed here in the meeting room. Then we'll be asking the question from the LinkedIn Live comment section, which were left out earlier. There was a question from Mr. Saidi, I guess. This was the name. Okay. I'm not sure if this was the question from Professor Mohamed, but there was Mr. Anas Saifi, who was asking the question that how the mechanism in depletion in dopamine neurotransmitter is responsible for anxiety and aggressive behavior in humans.
Yeah. The dopamine mainly is located at the ventral tegmental area, pleasure center in the brain, and its shortage or dysfunction, more accurate terminology, is causing lacking of motivation or amotivation, and it might be involved in the areas of lack of volition and lack of motivation in patients with major depressive disorder. and its involvement in aggression is not the primary, but it may be also involved in some aggressive behavior for more rise of the risk taking and the novelty of aggressive behavior. It raises the level of dopamine and causing compensation of might be shortage of already present dopamine, and it might be the explanation of the aggressive behavior in those with hyposensitive or dysfunctional dopamine system.
Question was from Dr. Yong Lee Jang. Would you like to please unmute yourself and come up on the screen, doctor? Now you can ask your questions.
Okay. Yeah. Thank for all wonderful lectures, all these professors and doctors. And I asked to Ryan, Mr. Ryan, I just wonder, we know that some objects could be act as a attraction object, we so-called transitional object for the some children, such as a blanket or dolls, could be soothing the mental anxiety or depression for these materials. So I just wonder, Turbobo could be more effective compared to other ordinary dolls, such as transitional object or real pets. So I just wondered, is there any other study result for comparing the things?
Yeah, so I think I sent you a text as well, direct to answer it, but I'll answer it a different way. Is so the study I mentioned in the presentation was a 3-month kind of pilot period. So in that 3 months, on the side, kind of unofficially, so I don't really have the exact data, but I was speaking to a number of, I think it was 20 psychiatrists who used it in their office as a resource to help their kid clients in their therapy sessions. And in those offices, they already had sort of, I want to say traditional stuffed animals where it's just your cute little cuddly thing. And then they had Turbobo. And they found roughly around in the high 80% of recipients said that their client picked Turbobo ahead of the stuffed animal or their plushie, just because they didn't know, I don't know if they were sure why they picked it, but they could feel it had a different sort of sense, like you mentioned, as a transitionary tool. It's definitely like a resource to help. Yeah, I don't know if that answered your question exactly.
Yeah, he answered that too. So I just wonder, we had some attachment of object for some people, and they highly attractive or stick to their some scent and flavor for their anxiety soothing. So Turbobo could be some other alternative method for that. But as a therapeutic material, I think there are some more evidence for their effectiveness compared to some other the kind of other dolls, pads, and materials for as a treatment method. So I just asked for that.
Yeah, so I think that was the question. Yeah, like, do you have any other therapeutic results compared with other ordinary dolls or real pets? The effectiveness of Turbobo is very impressive. I assume other mental attractions affect similarly. Yeah, you're right. The same kind of principles, of course, are out there. What kind of makes Turbobo unique is the way it combines all of them into kind of a hidden tool that the client generally doesn't even know is helping them. because they don't really know what's like under the stuffed animal plush. And that's unique to the marketplace. And as a resource, these things do exist separately, like a weighted blanket or a fidget spinner or just some kind of anything tactile, but there's nothing that really makes it into a personable kind of resource to not only increase the credibility and effectiveness of a private practicing psychiatrist, for example, but also making its efficacy more more successful just in the way it's personable and you kind of get everything all at once. So it's kind of like your one-stop shop kind of need for all those kind of physical sensory based needs.